Okay, welcome everyone. We will other people keep joining us as we proceed, and I want to take this opportunity to welcome all of you. You are all very welcome to this Day of Science webinar on the 25th of October, 2023, organized by the Makerere Lung Institute. I am your moderator for this webinar today. And by introduction, I'm Dr. Eric Wobudeya. I'm a senior consultant and a pediatrician and an epidemiologist at the Mulago National Referral Hospital, where I head the pediatric tuberculosis unit, and I've been involved in pediatric TB research for up to over the last 15 years. And in terms of just introducing our topic today, as you're aware, we are having a very important topic before us. And as we align with the Sustainable Development Goal number 3 of being healthy and have well-being of all people, palliative care has become an important aspect of health service delivery, and most importantly in children. And we know that post-TB lung disease is one of the key conditions that requires palliative care services, as children end up with chronic condition with chronic lung health, which requires chronic care. There's, however, limited data in this area, and the focus on this area is therefore very important as you look at children who have this problem, which is many times underplayed. We know that most of our children get pulmonary tuberculosis, up to 80%, but we have limited information or data on the lung health of these children after the complete TB treatment. And therefore, the webinar of today is very important for really very many reasons. And I would like to invite you to today's scientific discourse. And I know that to add both to your knowledge and to your advocacy for children who are having post-TB lung disease. So today we have two Polish expert scientists who are going to share with us their ideas on this subject. And that is Dr. Damali Nalwanga from MLI. Dr. Damali Nalwanga is a pediatrician, and she's an assistant lecturer and research fellow at the Makerere Lung Institute. She'll be sharing with us her experience with some cases that she's going to share with us. And also we are going to have Dr. Rebecca Nantanda, who is a pediatrician and a senior researcher at the Makerere Lung Institute. She has been involved in the area of lung health for quite some time, and she's going to be sharing with us some of the new the landscape of this condition in children, the burden, how we can identify it, and what we can do about it. And on that note, I would love to then invite Dr. Damali, who's going to be the first presenter for this session. Our session is intended for 1 hour, and we hope that you're going to be there, paying attention, write your questions. We'll be able to answer most of your questions at the end of the session. Thank you very much. Over to you, Dr. Damali.
Thank you very much for that kind introduction, Dr. Wobudeya. I'm trying to share my screen, but someone called Peter Nason is sharing. So if you could kindly stop sharing, I'll be able to share.
The admin, okay.
I hope that everyone can see my screen. Then
Yes.
it wants more. So I have to share again. Excuse me.
We can see.
The slides are not moving. I have to share this with you. Let's see. All right. So I'm going to be presenting a few cases just to paint the picture for us of what a patient with post-TB lung, of how a patient with post-TB lung disease might present. Peter, kindly stop drawing on the screen. Thank you. All right, so I'm going to present two cases, and they are meant to just show us their journey through the healthcare system, how they are identified or not identified for that matter, so that we can see how to do better. Abe Peters is still drawing on the screen. Could you kindly not do that so that we can see the slides?
And the administrator do something about it?
People are not going to be able to see the screen because it is. I don't know how people do it. Okay, so in the interest of time, I'm going to tell you the stories while an administrator helps us deal with the marks on the screen. So the first patient is a 12-year-old female who presented to the Mulago Hospital Pediatric TB unit, having had a productive cough for 6 months. There was no hemoptysis, but it was associated with chest pain for 2 months and difficulty in breathing. This is getting so much worse. But we are trying to find the administrator, so hopefully they can sort us out sooner rather than later. So this young 12-year-old girl had all these had cough and then difficulty in breathing, but also had weight loss and night sweats. And she had not had any history of contact with an adult with chronic cough or with diagnosed TB. And the immunization history was really not clear, but she had no BCG scar. So it's safe to assume that she was probably not immunized. So in examination, she was wasted, just like is reflected in the image, not severely wasted, but she was wasted, had moderate pallor, but no finger clapping or lymphadenopathy. And on respiratory exam, the obvious thing, there was a bit of chest asymmetry, as you can see, but the chest was not, rather the trachea was not deviated. It was in the normal position, and the percussion was also okay. She had normal breath sounds. However, she also had bronchial breathing in the left upper lung fields. The rest of the systems were normal. So she was investigated, and the ZN showed that she had AFBs on acid alcohol fast bacilli on both her samples, her sputum samples. And then when a chest X-ray was done, when they clear off all these signing, you'll be able to see the X-ray, the picture of the X-ray there. But there was a bit of tracheal deviation to the left. There was some right hilar adenopathy. You might need a little bit of faith to see that. But there was extensive parenchymal involvement, as you can see, largely in the superior lobe of the left lung. And the diagnosis of TB was made at that point, and the child was started on TB treatment as per the treatment guidelines. However, the problems persisted. The child still had pulmonary problems at the end of treatment. And okay. Hopefully the administrator is on top of this because, okay, thank you. So yes, the child was managed for TB, but still had problems, had pulmonary problems at the end of treatment. And the chest X-ray did not change much. Actually, it was mostly the same. So the team decided to make a diagnosis of post-TB lung disease at that point, because there are the Center of Excellence for Management of TB, and they were able to recognize it early. And they decided to consult with the cardiothoracic team on how this patient should be managed. However, at some point, the patient was lost to follow-up before they could agree on the way forward. So that's what happened to this first patient, and that's what their journey was like. We will see why this patient and not all the other patients that we see recover from TB, because we know that TB is preventable, but also treatable and curable. So we'll try and we'll see from the next presentation why some people are at risk of getting post-TB lung disease while others recover. So I'll now tell you about another patient whose journey was slightly different from this. So the second patient is RMV, a 14-year-old male who was referred from a private facility for evaluation with a diagnosis of post-TB lung disease. And this patient presented to the Makerere University Lung Institute. The symptoms at the point of presentation to the Lung Institute, and that's this year, May 2023, the complaints were chest pain, noisy breathing, sometimes wheezing, sometimes some other noises, had easy fatigability, so could not play as usual, and then had this cough that was on and off, but usually worse at night and whenever it was cold. But the child had no history of atopy and had no symptoms prior to 2019. So as you can see, the problems had taken a little bit longer compared to the first case I presented. But the siblings were well and didn't have any similar complaints. So I'm now going to go through the past medical history, and I'll request you to follow closely because it's quite a long story. So the child was first, the information we have is the child was first evaluated here in Uganda in October 2021. And this was because actually this happened in South Sudan. The initial evaluation was in South Sudan, but the child had been unwell for a while, since 2019. And he had had on and off cough, which, was treated as an upper respiratory tract infection every now and then eventually treated as pneumonia. But then with time, the child developed difficulty in breathing and fevers, weight loss. So the parents were concerned. They took the child to hospital for evaluation for TB. However, all the evaluations on sputum were negative. So when they did a chest X-ray and found that there was a pleural effusion and decided that this might be TB, the family was not very convinced because they had done several sputum tests that were negative. Of note also is that the HIV serology was negative. So basing on the chest X-ray, the clinician at the time decided to start TB treatment. However, because the parents were not very comfortable with the diagnosis of TB, they did not, they were not compliant. Not the parents, the child was not compliant, but obviously in pediatrics, the compliance of the child speaks a lot about the adults as well, or the caretakers. So they missed quite a bit of their treatment. And during this time, they went around looking for alternative diagnoses all over the place. They went to Egypt, they went to a cancer center thinking this might be cancer. And so during this time, you can understand why they were not completely adherent to the medicine. They were not sold on the TB diagnosis. So in July 2022, the child was reevaluated at another health facility. And they did some investigations, including gene expert, which was positive. But as you know, if the child had truly been treated for TB, a positive gene expert at this time might not be that surprising, probably. But they decided because the child had not been adherent to the TB treatment, it was probably better to start the TB treatment all over again. So the child was treated for TB after non-compliance, and this started in August 2022. Then in February 2023, they are again still shopping for a better diagnosis. They're not convinced about TB and that the child has been on TB treatment for a long time. She should be improving if it's truly TB. So they are seeking care from anyone who gives an alternative diagnosis. All this time, the child has symptoms. So in Feb, they did a chest X-ray that showed reticulonodular opacities with some loculated effusions. Unfortunately, I'm not able to project the films. I was unable to find them in time, but at least I'll give you the reports that are on file. They also did a chest CT at that time, and it showed still reticulonodular opacities, cavitations, and consolidation, but there were also widespread pulmonary calcifications. And then in March, they again are going around being treated for respiratory infection and being admitted anywhere every now and then within Kampala. They've been treated with very little improvement, and then they're finally referred to the Lung Institute. So now we are back to their presentation at the Lung Institute. Remember, I said that they presented with cough on and off. They still had some little difficulty in breathing, but they had fever, weight loss, and yes, that's what had happened at the point of presentation. So on examination, the child was really wasted, had no pallor, jaundice, or lymphadenopathy. But we also noted that on the ENT, there were enlarged nasal turbinates, especially in the left nostril. And then the respiratory exam, the respiratory rate was normal. However, there was reduced air entry on the right. And then the child also had some bronchi bilaterally, but more on the right. And then other systemic exam was normal. So we made an impression at the Lung Institute of post-TB lung disease with a possible underlying obstructive disease. But we thought that the child might also have chronic rhinitis based on the presentation and the exam. The investigation's done. The Lung Institute is able to do spirometry, so that's where we started. And so we found that the child had severe restriction. That's that their forced vital capacity and forced expiratory volume 1 was significantly below normal. And then the FEV1 to FVC ratio was also below normal. And then the chest CT, we reviewed the images with the radiologists here at the Institute and found that, yes, the child had consolidation with calcification bilaterally, and the left lung volume was significantly reduced. At that point, we thought that the child might have pulmonary hypertension, given the extensive involvement of the lungs. So we did a cardiac echo as well, but that was normal. So we decided that the child probably had post-TB lung disease, might have some other things going on that we are evaluating for, but the child fits the diagnosis of post-TB lung disease. And we have we are going to take them through pulmonary rehabilitation. Hopefully the patients will agree, the parents will agree and come back for this, this treatment. So what are the key lessons that we pick up from these cases? One, the need for early diagnosis and treatment of TB. It probably will save some. It did not save our first patient, but you can see that the symptoms had taken a really long time. So maybe for them, that's the risk factor. But delay in making the diagnosis, or during this time that you're delaying to make the diagnosis, TB is doing its damage and will increase the risk of post-TB lung disease. And then, of course, the need for adherence to TB treatment, for one reason, to prevent developing resistance. But however, the longer you take without taking your TB treatment, the more the bacilli survive long enough to do damage. So that's another point as well. Thirdly, If chest problems persist after treatment of TB, you should just consider an alternative diagnosis like post-TB lung disease. It's not that TB has refused to go away, so let us treat TB again. So if all the checks and balances are in place and the patient has completed TB treatment but still has problems, please consider post-TB lung disease. And then, of course, what is highlighted here are the challenges in management or post-TB lung disease, because it's one thing to make the diagnosis, but then what to do. The first patient got lost to follow up as there was a bit of a dance between the cardiothoracic surgeons and the TB management team. And then the second patient, hopefully, after all this time of not having a diagnosis, hopefully they will benefit from pulmonary rehabilitation. But there is significant challenges, not only in making the diagnosis, but in managing post-TB lung disease as well. Thank you. That's it from me.
Okay, thank you very much, Dr. Damali. I think that is a very good icebreaker or opener concerning this topic, and putting into perspective the issues about early diagnosis, the issues about being able to recognize that children after treatment and they continue coming back, they are likely to have post-TB lung disease rather than having continuous TB. I know many clinicians keep giving TB treatment many times without considering that this could actually be a complication of post-lung TB disease. And I think with that, that's a very good interlude. As I said, please write down your phone, your questions. We shall be able to pick them at the end. And this is a good time for us to be able to introduce Dr. Rebecca Nantanda, who I already introduced before. She's a senior researcher at the Makerere Lung Institute, and she's been involved in lung disease research for quite a while, and even care. And so she's here to give us insights on this condition and what we can do about it. Dr. Rebecca, you're welcome. Over to you.
Thank you, Dr. Eric. Good afternoon, everyone. So I'm going to share my screen just in a short while. But we're going to try and see if we can fix the problems we've had regarding the hacker. So give me just 1 or 2 minutes. So good afternoon once again. I'm hoping we've fixed the issue of the hacker. So we are going to continue with a post-TB lung disease, specifically in children, after that introduction from the cases. And so I'm going to go through the burden of post-TB lung disease in children. We'll try to discuss the mechanisms of post-TB lung disease, what we have now or what we know about diagnosis and management, but very important for the scholars here to identify the knowledge gaps so that we can find a way of filling them up. So just to introduce that, we know that TB is a big problem in world over, but specifically 11% of the infections occur in children. And pulmonary TB is an important cause of chronic respiratory diseases and impairment, especially in low and middle income countries. So just to define what post-TB lung disease is, So this is the working definition that we have right now, but post-TB lung disease refers to the presence of chronic respiratory abnormalities with or without symptoms. And in most cases, this could be attributed to previous TB disease, at least in most parts. So what I'm trying to say that for some people, the symptoms are there, but for others, they don't have the symptoms. But when you do the investigations, you'll find that they have either lung function abnormalities or radiologic abnormalities, suggesting that they have a problem with their lungs. And specifically, when we talk about clinically relevant PTLD, is when we have the symptoms that are most likely attributable to previous PTB and cannot be explained by any other respiratory condition. So the journey is usually trying to find out what else could be the problem. And at this point, probably you could think of it as a diagnosis of exclusion. But why are we discussing PTLD today? First of all, there is evidence that there is high risk of death upon completion of TB treatment. So for somebody who gets at the TB disease, after completion of that treatment, they still have a high risk of death. It's actually 3.8 times higher compared to the general population. And there is evidence emerging, at least in the adult population, that PTLD is associated with high morbidity as well as mortality. But also very important, it impacts on the quality of life for the people suffering from this PTLD. Specifically focusing on the children, children's lungs are still growing. We know that lung growth and development takes place right from in utero until we're about 25 years of age, and then the decline starts. So for children, it's a problem because it affects their lung growth and development. And as a result, they end up having lower than predicted lung function trajectories. And this puts them at high risk of developing other lung diseases such as asthma, pneumonia, and COPD in adulthood. So we still have very, very little information regarding PTLD, but hardly any studies on PTLD in children, although it has been recognized clinically. So there is a recent systematic review and meta-analysis was done in 2022. It included 32 studies in low and middle income countries. 21 of these were actually from Africa, and it involved a total number of 6,225 participants. But when they analyzed the results, the pooled prevalence of PTLD was 46.7%. And this was as evidence from the abnormal lung function. But when they looked at those who actually were symptomatic, meaning they had persistent respiratory symptoms, they were 41.8%, and 64.6% of them had abnormal radiological findings. Specifically in children, what I can say is that it's really under-recognized. There are very few studies to date. And in Africa, I could only find one study in the Gambia, involved a small number of children that were 52, aged 6 to 15 years. So they looked at children who had completed TB treatment, and they did lung function testing, specifically spirometry. And they found out that 38.5% of them had lung function abnormalities. So what are the pathological mechanisms that are at play in PTLD? It is thought that these are host pathogen interactions that lead to immune responses. But important to note is that these immune responses are actually dysregulated. And therefore, there is also emerging evidence that the host genes may actually be modulating these immune mechanisms. And that's the way the severity of the PTLD is influenced. And there is also evidence emerging that what we see among patients with PTLD actually starts when they still have the active TB disease. And so I think that takes us back to the idea of early diagnosis and proper treatment. Probably that could minimize the injury. But when people have PTLD, they have permanent changes in their lung architecture. And this may be partly due to the aberrant wound healing processes that happen in these people. And one of them that has been pointed out is the excessive collagen deposition, as well as fibrotic scarring. And as we shall see later, this is responsible for some of the symptoms and the radiological findings that we get in these children. So again, more research has identified specific immune mediators. There are quite many, but just to mention that, for example, anti-necrotic factor alpha, TGF-beta, interleukins 12, 6, 8. And these are responsible for tissue remodeling and eventually leading to lung function impairment. And the other thing that has been noted in research that there are these transcription factors, cytokines and chemokines, and these ones drive expression of the tissue degrading enzymes, and these are the ones eventually lead to the damage, or they actually directly involved in mediating the cavitation and or fibrosis. These are some of the features that you'll find in people with post-TB lung disease. So it's either direct influence or through the enzymatic action degrading the tissues. There has also been noted that these people with post-TB lung disease actually have chronic local inflammation, but those who have been monitored along the way, they seem to develop new spots of inflammatory lesions despite the treatment, and this one may also be contributing to the picture that we see in TB lung, in post-TB lung disease. So when we look at the pathological features, they usually have nodular infiltrates, they may have fibrosis, they may have cavitation, bronchiectasis, pleural thickening, a mixture of these features. And when it comes to lung function, looking at their lungs, they usually have airway dilatation, they have reduced airway elasticity, muscle destruction, especially of the bronchial walls. And of course, there is usually parenchymal and vesicular wall damage. And so all these pathological features put together, they may be in the same patient, or they may be one or two of them. Eventually, they lead to what we see in the patients with post-TB lung disease in terms of symptoms. So there is a group of scholars from Pakistan. They try to think through what exactly happens when somebody has PTLD. And this is what I was just describing. I'm not going to go through the details of this, but just to show that these factors that I talked about, the chemokines, the cytokines, they interact, and eventually they lead to some of these lesions like the granulomas, the cavitation, the fibrosis. And as a result, when we look at the lung function of these patients, they either have a restriction, they have an obstruction, and then they also have pulmonary impairment. So there are a lot of things going on at tissue level involving different cells, different chemokines, and transcription factors that eventually lead to this process of people having these lesions that we see in post-TB lung disease. But to make it, I think, simpler, they drew this picture, and just to show the fact that in these patients, they have excessive inflammation, there is airway narrowing, cavitation that I talked about, there is bronchogenic spread and endobronchial disease, and so many other things. I won't go through them, but you can see there is cavitation, airway narrowing, there is inflammation, we have bronchiectasis, there is excessive fibrosis, there could be stiffening of the lung parenchyma, bronchovascular distortion, pleural thickening. And within the lungs, when we do the lung function testing, these manifest partly as obstructive lesions or restrictive lesions, meaning that when you have an obstruction, there is reduced capacity to actually exhale air out of the lungs. And in spirometry, this is evidenced by a decrease in the FEV1, which is forced X-ray volume in 1 second. And if it's a restriction, there is reduced capacity to inhale to the full potential, meaning that the lungs cannot expand maximally. And as a result, you end up with a decrease in the forced vital capacity or an increase in the FEV-FVC ratio. So what are the clinical manifestations? Like all my colleagues have previously said, this is a disease which is just picking up in terms of recognition. So it hasn't been well characterized. And so some of the symptoms that have been seen in these children, they have chronic or persistent cough. If somebody has had a treatment for PTB, they have completed, but they are continuing to complain of the same symptoms, and you've assessed them and you can't point a finger at what is going on, it's a time to think about the possibility of post-TB lung disease. They experience breathing difficulties resulting from those pathological features that I've mentioned. Some of them actually have wheezing. So not everybody who is wheezing has asthma. They may be having post-TB lung disease. They have dyspnea, and they certainly have decreased exercise capacity. But there is a lot that we need to try and find out that is going on in terms of clinical manifestations. But this is what we currently seeing. I just wanted to show a few radiological features of post-TB lung disease, both on X-ray and CT scan. So this is somebody who had completed treatment, the 6-month cycle of drug-sensitive TB, PTB. And that's how their chest X-ray looks like. And in this chest X-ray, certainly we see the interstitial markings that are increased in both lung fields. But when you look at the CT scan, it's even more clear that we have fibrotic changes that are going on. So you can imagine somebody has had the 6-month course of the anti-TB, and as an individual, you'd think everything is fine now. I've done my treatment, I should be fine. But then you end up with such a fibrotic lung, and this is responsible for the symptoms that we see in these patients. This is another patient who also had completed their treatment. So there was loss of lung volume, and these are the films that were taken at the end of the treatment. What we don't have, they didn't show what it was like before. But like I mentioned, that people think this process starts during the active TB disease. But this patient had the loss of lung volume. Almost the entire left lung was gone. And if you look at the CT scan, those are the features that you see, that we really have the left lung completely, not functioning, so to speak. So these are features actually showing that post-TB lung disease is a problem, and that children. And I'm going to specifically talk about for children who are 6 years and above, because that's where we're able to do spirometry. So they usually have a low force expiratory volume in 1 second, which we call the FEV1. And that is usually a mark of airway obstruction. And like I mentioned earlier, there are problems within the airway in post-TB lung disease leading to airway narrowing. They also have a low force vital capacity, meaning that the expansibility of their lungs has been affected. Usually this is because of fibrosis. And then people have done the studies. In this one study where we had children doing spirometry, the most common ventilated defect is restrictive, meaning that they're really unable to inhale maximally. And this is how their lung function is affected. But to note, some of them have obstructive defects, others have the mixed type, and a good proportion of them may actually have normal lung function. And then when you look at the diffusion capacity of oxygen and carbon monoxide, meaning that they have a challenge with alveolar capillary membrane, then some of them are also affected. So the problem is not only about the airways, but also the diffusion of oxygen from the alveolar end into the capillary end and vice versa for carbon dioxide. And so this makes them, some of them actually have chronic hypoxemia. And what we don't know is how to support some of those patients yet. So I just want to share one of the studies. That is the study that was done in the Gambia. It was a small study involving a small population, just about 52 patients with post-TB lung disease and 86 controls. And as you can see, if you look at the FEV1Z scores, the FVC, as well as the ratio, and all of them were significant. There was a significant difference showing that those children who had post-TB lung disease were actually more likely to have a low FEV1, a low FVC, as well as the ratio. And significantly that if you look at the 52 patients, 20 out of them, which is 38.5%, actually had abnormal lung function, as compared to the 17.4% of the control. So again, I don't know whether somebody has hacked again. My slides are not showing. Let me just reshare. So again, the problem of post-TB lung disease in this population is a problem leading to abnormal lung function. So one of the questions people have asked, if I do the lung function test after the end of the TB treatment, is it possible that actually the lung function abnormalities that I am seeing now were there before the TB setting? Because we also know that people who have poor lung function are at high risk of most of the lung diseases. But luckily, we now have evidence from one of the very big cohort studies in South Africa in PAL. It's called the Drakensberg Child Health Study. And this is a study where they recruited pregnant women at 20 to 28 weeks of gestation. And then they started measuring the lung function in the offsprings from 6 weeks. They measured again at 1 year and then at 5 years. And so because they have been following up these children, they have been able to determine those who get TB. And therefore, they have the evidence of what their lung function was like before they got TB and what their lung function has become after TB, treating TB. So they were able to diagnose TB in 96 children, and they used chest X-ray. They also did induced sputum to check, and they did gene expert, ZN stain, and culture in addition to the symptoms. So they actually had confirmatory tests for all the children that they included in these studies that they had TB. The children were treated using the standard guidelines for TB, and then they measured their lung function. For those who got TB less than 1 year, they did the lung function again at 1 year and compared the lung function at 6 weeks and at 1 year. And then those who got TB after 1 year, they were able to compare their lung function at 6 weeks, at 1 year, and then at 5 years when they had completed the TB treatment. So they did a number of lung function measurements as opposed to the older children where we do spirometry. For the younger children, we do tidal volume. They were also able to do fractional exhaled nitric acid, which is a mark of airway inflammation, specifically eosinophilic inflammation. Then we also measure the time to peak tidal X-ray flow over the total X-ray time. These indices give us a marker of how your lungs expand, but also they give us a sense of whether there is an obstruction. So these are the results. So for the children who were diagnosed with TB between 0 and 1 year, when they looked at one of the lung function variables, that is the time to peak tidal X-ray flow over total X-ray time, they found that those children who had TB had lower or reduced that TPEF ratio to TE ratio. The same thing when they looked at the fractional exhaled nitric acid, they found that those children who had suffered from TB, they had a higher level of fractional exhaled nitric acid, which we call FeNO, meaning that they were more likely to have eosinophilic airway inflammation compared to those who did not have the TB. And then when they looked at those children who developed TB between 1 year and 4 years, again, it was found out that those children who had TB had lower tidal volumes and a reduced ratio of the time to peak tidal X-ray flow to total X-ray time. So the bottom line is that when children get TB, their lung function is affected, and therefore they end up with either restrictive or obstructive lesions, as evidenced by these results from this cohort study that we have seen. So a group of people who are looking at PATLD, they sat together in one of the symposia, I think that was 2020, and came up with some standards, which we are now using as we do more research to try and find out what can we do for people with post-TB lung disease. So they developed 6 standards. And the first standard is that all patients should be assessed at the end of TB treatment for possible sequel of the TB and therefore PTLD. So the recommendation is that I think the TB program, I think that would be the most opportune moment, that when you say the person has completed their 6 months or 4 months, whichever regimen they are on, even if it's MDR TB, it is important that we assess these people, and it could be clinical assessment combined with radiology, and where possible do lung function measurements, because it's not good to send a person out when there could be, they're still having persistent symptoms, and potentially they could get care for their post-TB lung disease. And not everybody who has post-TB lung disease could benefit from pulmonary rehabilitation, which is the one thing we are able to offer now. So again, we need to assess those patients and identify those ones who can benefit from pulmonary rehabilitation and send them for PR. And when it comes to pulmonary rehabilitation, it's not a one shoe fits everyone. So we do individualized care. So we adapt the PR program for the specific patient needs and different settings. So you may find that the way they do PR in Europe is a little bit different, the way we do it here, the way they do it in South Africa. So again, we have to bring it home into the context. I know there are sometimes when we've had the session, some of them here at the Lung Institute, but then we instruct the patients to continue at home, and then they just come back for review for various reasons, especially the economic reasons. And then as you offer the PR, evaluate its effectiveness through follow-up, because if it's not working, there is no need of going on with it. But if it's working, then you know what works, and maybe you can have a sense on what lung capacity that person will eventually have, as well as really the physical activity. Education and counseling is very important. Like I mentioned, when you're signed out of the TB program, you should be happy that you've completed the TB. They do the sputum and they say you don't have any germs left, only to continue with the persistent symptoms. So it's important that we educate patients as well as counseling them, as well as the caregivers if the child is younger. And then they recommended that we need to start having public health standards highlighting the need to record these changes in patients, changes in patient outcome resulting from PR. So what basically we are saying that much as pulmonary rehabilitation is something that we are offering, we don't have very good body of evidence showing the effectiveness of PR. So we need to start documenting and highlighting the importance of PR for people with post-TB lung diseases. So I want to highlight some knowledge gaps, and I'm hoping that maybe after this discussion, we shall try and see how to deal with this. We do not know of all the children who finish the TB treatment, how many of them, or what are the characteristics of those ones who will actually end up with PTLD. So we don't know the risk factors for PTLD in children. Adults have some information, but for children, we don't know. So the only thing which we have found so far is that people who need retreatment are more likely to have PTLD, like the case that we had earlier, and those who are underweight. So I don't know whether underweight is because of the TB or because of the chronic symptoms, but that was one of the findings among those studies that was done. And then when we see these patients, we need to characterize what are the clinical features of these patients? What are the radiological findings? What are the pathological findings? Because some of these things may tell us more information about what is going on. For example, are we able to look at the immune responses? Are there some medications, maybe the anti-IL-12 or 8 or 4 that is going to help us kind of prevent the progression of those lesions, and therefore we prevent post-TB lung diseases? We do not know. We do not know the disease progression. If we diagnose PTLD, for example, maybe 2 months after TB treatment, what is the cause of this disease? Physiologically, pathologically, clinically, what is the quality of life? We do not know whether the damage is reversible, or it remains static, or it progresses. We don't have really those cohort studies that are able to describe that. And so we are not able to do much or to have some predictions at the moment. We need to start thinking through interventions. What are those interventions that we can do to prevent post-TB lung disease? What about the treatment for post-TB lung disease? We know that pulmonary rehabilitation helps, but we don't have good studies to show its utility and effectiveness, specifically in children. Most of the studies have been in adults. So the pediatricians, we need to raise up to the occasion and see how we can help our children who suffer from post-TB lung disease. It's recommended that we probably start doing routine chest X-ray and spirometry at the end of the TB treatment. We don't know its effectiveness in clinical, cost effectiveness. Is it feasible? Is it acceptable? Is it possible to actually integrate this in the national TB program? Because the fear is that once people get out of the TB program, it might be harder to actually trace them and do these screening activities at when they get the symptoms. So I just want to conclude that PTLD is actually a big problem in children, which is under-recognized. As we have seen, it's associated with significant lung function abnormalities. And these lung function abnormalities actually lead to chronic diseases later in childhood or adulthood. So it's very important that we try and prevent, or at least treat to prevent this scenario where you are moving from TB to asthma to COPD, so that you really have poor lung health throughout your life course. And like I've just mentioned, there are many gaps in understanding PTLD in children, but we need to really find a way of addressing them very, very urgently. Thank you so much for listening to me. Back to you, Chair.
Wow, that is I think that's very interesting. Thank you very much for that presentation. It's clearly very enlightening. And for our audience, I hope you've been able to pick up a few things. You clearly see that from this presentation that post-lung TB disease is a real issue in children. However, the limitations that we do not have as much information as we need in terms of even predicting who's going to have post-lung TB disease, how the children look like at baseline, and then what happens to them later on in life and how they grow. So a lot of gaps there, and we thank you very much, Rebecca and Damali, for that presentation. I'd want to ask if there are any people who have questions. Would have asked you before to post them in the chat so that we could both pick on your questions. But nonetheless, you can be able to raise your hand and ask your question, and then we'll be able to respond to it. Do we have any hands up? Okay, put your hand up, and then you can be able to give you the opportunity to be able to ask a question. Any questions? No questions. What about in the chat? Do you have any questions in the chat? Wow. Okay. It is so there's no much information there, but okay. Imran, I hope the administrator can be able to allow Imran to say his question. There's one hand up, Imran M. Please unmute and ask your question.
I do not think that's the person we can recognize. So
we don't recognize the person.
Yes. It's been on the.
And then the others, so administrator could be able to unmute the people who should be able to answer the question. You have 4 hands up.
Hello.
Yes, Joel.
Yes, Dr. Wobudeya and Dr. Nantanda, Dr. Damali, thank you. A very good presentation. And I want to ask, yes, I'm asking, so how do we handle the post-TB lung disease now that we are getting to know about it? Do we use steroids? Do we use? So how do we go about it? Yes. Thank you.
Thank you very much, Joel, for that question.
Great, thank you. Welcome, sir. Great.
The other people, could you be able to write your question in the chat? Jean? I think we can recognize Jean. Can you unmute and ask your question? Jean Evangelana.
Thank you for the presentation. I came in a little bit late, so I did hear about that case. However, while in the pediatric chest clinic on Ward 15, we've had a number of children being sent to us for management. So maybe also with a person who asked right before me, what is the role of the pediatricians and the team of people who get such patients? Because yes, many of them come in with history of wheezing, but apart from dealing with the wheezing, I normally see these children are put on azithromycin, sometimes prednisolone 3 times a week, and I wonder, like, what's the length of time you're supposed to be managing them on those treatments, and what's the definitive treatment really for such patients apart from managing obstructive lung disease that causes wheezing? Thank you.
Okay, thank you very much. Can we have those 2 questions answered? I think they are quite loaded. Rebecca?
Hello.
Unmute Rebecca. Rebecca, did you get a question? We have 2 questions. It's about how do we handle, and then what is the role of the pediatrician in this team, and how long do we do these antibiotics, and that is commonly given for these patients. Unmute the administrator. Could you please unmute Dr. Rebecca?
Sorry.
Okay.
Yeah, I wasn't able to unmute myself previously. Thank you so much for the questions. I wish I had specific answers, but like we mentioned earlier, it's a field which has a lot of gray zones. So Dr. Chimera asked, how do we go about it? I think the first thing is to recognize if somebody comes in with respiratory symptoms after they've completed their TB treatment, and you've assessed and it's not anything else, kind of think about post-TB lung disease. And like I mentioned earlier, it manifests in different forms. It could be a fibrotic lesion, it could be an obstructive lesion, it could be restriction, it could be so many things, it could even be bronchiectasis. So one of the things that we do when we do that assessment of the symptoms, then we would send them for radiological investigations to try and characterize the underlying lesion. But we also do the lung function testing to find out they have a restrictive disease. Do they have an obstructive disease? If it's an obstructive disease, is it something that is reversible with short-acting beta agonists? We are basically just trying to work them up and see what is it that we are seeing, because we don't have very clear information on what is going on. And so sometimes they may come and they have a supra-infection on their post-TB lung disease. It could be, and so if they have a productive cough, please still go ahead and do the sputum analysis and find out, could it be an atypical bacteria? Is it typical bacteria? So that you're able to treat the infection that they have on top of their PTLD. And so in cases where you find that we've probably given azithromycin, those are some of the patients. We are not specifically treating the PTLD, but we are treating what we are finding. You probably could call it a complication of PTLD if there is something like that. Or if they have wheezing and we've put them on short-acting beta agonists and we put them on inhaled corticosteroids, it's because we've done the test and found out that the obstruction is actually reversible. In a way, trying to relieve their symptoms. But in terms of definitive treatment, for now, we do not know what is the definitive treatment. So we treat what we see and according to what the investigations give us. So pulmonary rehabilitation. So basically, these are physical exercises. It's kind of a gym, if you could figure out how a gym it is, but they're scientifically designed and prescribed and therefore delivered. And all they are trying to do, because many people who have post-lung disease at the end of they are weak, they cannot walk uphill, some of them cannot even do the basic activities of daily living, they can't carry a jerry can, they can't do this. So these physical activities are actually meant to kind of build their capacity for exercise, exercise capacity, kind of strengthening activities. And that's why they're really like physical activities. Your lung function, if I measured your lung function before and after the pulmonary rehabilitation, it may not change much, but your capacity to do activities of daily living, to be able to go to work, to be able to go uphill has actually improved. So pulmonary rehabilitation eventually makes somebody be independent. It improves their quality of life. But still, like I mentioned, not everyone is going to benefit. So we also screen who is going to benefit from pulmonary rehabilitation, who will not benefit, and we also monitor their progress. So it's kind of a program over a period of time where we take them through the exercises and we measure the response to those exercises with a goal of making them as independent physically as possible. But like I mentioned, in children, we still have no information on how they would benefit from pulmonary rehabilitation. We know a few of the adolescents we've worked with, they benefit from it, they're able to go back to school. The adults, yes, but there is lack of information in the children. So I think that's what I can say for now, but Dr. Eric, we are lucky to have you as the expert. You can add. Maybe I'll respond to some of the questions that are coming up in the chat.
Yes, please.
So how common is PTLD in Uganda? We do not know, but thankfully, I know there are people on this call who are going to conduct studies in post-TB lung disease in children, and Dr. Wobudeya is the PI. So soon we are going to have information. At least I know of 2 studies that are coming up. So we are going to be having some information about the prevalence, the risk factors, but also very important to describe the quality of life of these children. So something is coming up. I think we shall follow South Africa and the Gambia in trying to describe post-TB lung disease in children. I've talked about PR. How is it done? I think I've briefly described what it is, but just to let you know that it's a program, it's scientifically delivered. So you just don't tell somebody to exercise. You need to evaluate them before, give them the level of exercise tolerance they can handle, and then upgrade over time as you monitor the outcomes. So somebody says, upcountry where lung function tests are not accessible should refer to the Lung Institute for probable PTLD. Yes, we are able to do lung function tests, but I know do the symptom screen, you can do the radiological investigations, and then you can send them for lung function tests to try and find out how their lungs are functioning. And for possible pulmonary rehabilitation, because we have a program here which we offer for especially for adolescents. For children, we don't know much yet, and that's why we're not offering yet pediatric pulmonary rehabilitation services. Let me see if somebody's asking, Doctor, I'm requesting to find out this post-TB lung disease. In which level of TB is it common? Is it in mild drug-resistant TB? So we haven't seen studies which shows why it's most common, but maybe just thinking through, because I mentioned that post-TB lung disease is really an entail of what happened during active TB disease. We know that when somebody has drug-resistant TB, they're on top of that TB disease itself, they are using drugs that are potentially toxic or quite toxic to some of these people, and maybe they cause more damage compared to somebody who might have drug-sensitive TB. But the bottom line is that we do not have comparative studies. But either way, what I would say, if whether we've treated somebody for drug-resistant TB or drug-sensitive TB, to the extent possible, do a screen, at least a symptom screen, as you sign them out of that TB program. I don't know. I think I've answered what I'm able to see.
I think there's a question on. I think it wasn't a question from Imran. Probably it is a comment. It's one look at the pathogenesis, and these are theories of pathogenesis. So hope you appreciate that, and then it thinks that giving the treatment against that is kind of redundant, and therefore is wondering whether steroids are helpful. He thinks that since steroids shut out the whole system, maybe they could be helpful. I think that maybe over to Rebecca, if I can make any comments here.
Yes, steroids or no steroids, we always need to get back to what is going on in those lungs. Like I mentioned, some of them have chronic inflammation, some of them have cavitation, some of them have bronchiectasis, others have pleurothicany. It's really a heterogeneous picture that you're looking at. So we cannot say that for everybody who comes in, give them steroids. There may even be a problem for some of them. And so, and the issue of these dysregulated immune mechanisms, theoretically, you would think that maybe if you give steroids, you would try to regulate. But these are the things that are going on probably during active TB disease. And we are making the diagnosis after all this has happened. Maybe you would direct it to what they have found as new inflammatory, lesions that are coming up after ending the TB treatment. But we really do not know whether who will benefit from steroids, who will be harmed by the steroids. For now, what I would recommend is to try and characterize patient and try to find out what is it that is going on in these lungs. What are the potential things that I can do? But for those who have reversible obstructive lesions, they could benefit from inhaled corticosteroids. So you give it at a trial and see whether their symptoms improve, and then you can continue as you continue following up with the patient. So we need research to see what can we do for these patients. We do not have definitive treatment. It's a heterogeneous disease. There is severe, lack of information. That's what I can say regarding that.
Okay,
So
thank you very much.
Okay. Oh, can I finish that chat? Somebody, and this is quite
Yes.
interesting. Do we foresee diagnosing COPD in children or young adults? So for now, COPD is a disease of adults, and I think the study from Uganda, person maybe 26 or 36 years who had COPD. But if you look at the characteristics of COPD, it's not just about lung functioning. Lung function tests, there are so many other features you put together to diagnose COPD. But yes, in young adults, probably, but in children, we don't know whether we'll reach that point just because of PTLD. And maybe when we do these cohort studies to try and follow up these patients, probably something which we shall find out in years to come. I think that's what I can see. Dr. Eric, please, you can go on.
Okay. Okay, thank you very much. As usual, these topics are very interesting, and time is not always our ally. We just want to bring this to a close. Just some interesting questions there about transmission. That why is someone who's finished TB treatment still transmits infection to others? That statement is not true. Effectively, people who start on TB treatment, they are non-infectious in about two weeks. They're non-infectious. So it's not true that when you finish TB treatment, you still can transmit. And I think that's one I wanted to quickly speak to. But the others have been well answered. The pulmonary rehabilitation has been described already. And we want to appreciate everyone for joining this. This discussion, as you're aware, is a work in progress. This is an area where there's limited information. And therefore, we are calling upon all of you who joined this, plus all the pediatricians around, and the researchers, to be able to look at, to be able to cover up some of these gaps, especially in terms of care. And if we're able to predict some of these situations early enough, maybe probably could change the course of the disease of the children. And also, if we can be able to quantify the burden of post-lung TB disease, then we can be able to have a basis to advocate for more resources, and maybe also be able to expand the lung function tests, because there's a question there that if upcountry they have no lung function tests capacity, should they be sending participants to MLI? I think for now, for those who really require these tests may have to come forward. But however, once we're able to characterize this condition, then we shall be able to use to be able to advocate for these services to be provided all over the country, so that people don't have to come to Kampala to have lung function tests. So I think with that, I want to thank you very much. I think this has been very well summarized and very well discussed by Dr. Damali Nalwanga and Dr. Rebecca. I think it's been very well done presentation. Thank you very much, and I want to appreciate the whole audience. Thank you very much for being active and participating and being able to bring forth your questions and being interested in this topic. As many of you have taken note, please follow the link in the chat. For those that require CPD points, you'll be able to follow that and be able to have your CPD points accredited to you. So thank you very much. And with that, I want to bring this webinar to a close. Have a good evening. Bye-bye.
Bye. Thank you, Chair, and thank you, everyone. Have a